Thanks. I'd like to invite Dr. RAJANI BATTU, who is a senior vitreoretinal surgeon, and she has a keen interest in genetics and hereditary disorders, and runs a wonderful institution called ISTEM. Am I right, ma'am?
Yes. Morning, everyone. Thank you, Lee. Thank you for that. Thank you for the invite here. Yes, I'm part of. I have a startup called ISTEM. That's not the point of discussion here. So, predicting prognosis and diagnosis in retinal dystrophies. That's the topic, and so I'm going to look at first the diagnosis, and then we'll look at the prognosis. And this is, I think, especially important because most of us end up having to tell patients that the prognosis is not great, and so it's important that we know what to tell them. In terms of diagnosis, so we look at three things. One is the okay, so that doesn't work. All right. So the clinical imaging and the genetic markers. I'm just going to start with a couple of cases. The first one is, thank you. Yeah, the first is a 8-year-old girl, a very soft-spoken girl, who presented with decreased vision over a few months. The father gave the history that she was struggling to read. There was some history of fever prior to that. Her best-guide vision was 618 and anti-segment normal. The fundus had been reported to be normal over 2 examinations. So a possibility of malingering was being considered, and a psychiatric opinion sought. So this was the fundus, more or less normal, except for probably some heightened macular reflex in both the eyes. And that's the infrared image, which shows something similar, whereas the clincher is the autofluorescence. So you do see that there is a significant loss of autofluorescence at both the maculae. And when a OCT is done, there is a considerable amount of ellipsoid loss all through the macula, except for this, nasally in both the eyes. So this patient, the ERG was normal. And so what did this child have? So this is one of the classical presentations of early onset Stargardt macular degeneration. So this child actually had 2 homozygous mutations, 2 mutations in the ABCA4 gene that does cause Stargardt. And so early onset Stargardt is especially something that's very easy to miss. I must have seen at least about 6 to 7 children in the last few years who all get diagnosed with other things and go from for multiple consults simply because simple autofluorescence or OCT is not done. The importance of history again. This is a 6-year-old boy who was referred for a routine examination by the neurologist. So this child was being treated for infantile spasms and subsequently epilepsy, had some amount of developmental delay. The parents were very keen that they have a second child. A whole exome was done by the neurologist, and it did not show anything. No mutation was identified. So referred for routine examination, but when persistently asked, the parents did feel that there was some vision difficulties. I think especially the last 2 years, many of these children sitting at home, parents have struggled to identify whether the child has a vision problem and so on. So the best guide vision was 636, anti-segment normal. And the fundus, again, in this, I think it's a little easier to make out that there is some changes there. And autofluorescence is obviously significantly altered. And the same with the OCT, significant loss of the ellipsoid zone throughout there. So in view of the new findings, we decided to reanalyze the same sample, and this is what we found. Here we not only found that the child had 2 mutations in ABCA4, the child also had a mutation that caused the systemic problems. So this was called the SPTBN1 mutation associated with multiple systemic problems. The take home here is that a complete phenotype is a must. So doing a genetic analysis without a complete clinical information is absolutely not okay. So you cannot interpret a genetic testing without a complete phenotype. There are a couple of specific signatures that you can notice. So in this, for example, this is a young man who's got the classic coats-like response. There is also some amount of this clearing around the vessels that you see of the RPE. And then you have the classic pigmentation. So this is, so these people also have a very thickened retina with significant loss of the retinal lamination. This is very characteristic of a condition called a CRB1 mutation or a Crumb's homolog. And so a complete examination is a must. So this is a young man, completely normal retinas, normal fundus, normal OCT, except when you look at the periphery, you see this. You see these large areas of pigments. So this is a form of Best disease. It's called autosomal dominant vitreoretinopathy. So a complete examination, clinical history, all of that is an absolute must. This is something that's known. A young child, 11-year-old child presenting with drusen with a normal OCT. These are very classic of a condition called membranoproliferative glomerulonephritis. This child incidentally went on to develop renal failure subsequently. So what do we do with the prognosis? Again, we look at the same three patterns. We look at the clinical bit, the imaging, and the genetic information. The age of onset is extremely important in these patients. The earlier the age of onset, generally they are a lot more severe and the progression is a lot more rapid. And whether they're associated systemic conditions, that's extremely important. And how have the other family members fared with the similar condition? I think the commonest that we use often across the board is OCT and autofluorescence. And so obviously, this if this is a child who presents with, this is about a 9 or 10-year-old child, where you see a significant amount of ellipsoid zone remaining, versus this is a child, similar age, but something called, early onset retinal dystrophy, you would definitely know that the prognosis here is much better than this child. So autofluorescence, I think, Tony Robson from Moorfields did a lot of work on this. The loss of autofluorescence and the progression constriction of this ring becomes an extremely important, marker to understand prognosis. There are algorithms that can help us, especially in situations like Stargardts and so on. This is a girl I have seen between, a young girl, about 14 years old, in 2016 and 18. So if you look at the ellipsoid zone, you don't notice much of a difference. Whereas, over a period of time, you do notice that, so there is a significant loss of the ellipsoid zone. Today, there are computer algorithms that can do for this. We don't have to do this manually. Especially with Stargardt, a lot of work has been done in terms of the prognostication. In terms of, so there is one way to do it, with use of ERG. If your full field ERG is normal, the prognosis is actually very good. Sometimes the cones, ERGs get involved, and if both the cone and rod ERGs are, affected, then the prognosis is much worse. So based on the fundus autofluorescence, Fujinami sort of, described how this can be seen. So this is, for example, a type 1 autofluorescence where you have a localized loss at the macula, but the background is generally homogeneous. So that's a type 2, where you have a localized loss at the macula, but the background is considerably heterogeneous. And the type 3, where the loss at the macula is just not just focal, but multiple of them, and then a generalized, heterogeneous background. So obviously, it is the increasing worsening of, severity. We do look at multiple others, including the fields, ERG, adaptive optics, microperimetry, and so on. And how do we look at in terms of genetics? Does it really make sense? Do we understand, how severe a mutation is? Can we prognosticate based on the results that we get? So as a rule of thumb, X-linked diseases, X-linked retinitis pigmentosa is the worst of all. That has the worst prognosis, followed by the autosomal recessive inheritance. Again, generally, autosomal dominant diseases tend to do much better than others. In terms of the actual mutations, nonsense mutations are generally more severe. I'll just show you an example of what that actually is. So in terms of macular dystrophies itself, some of them actually tend to do well in terms of, like achromatopsia. It's a stationary disease. Youngsters presented with pattern dystrophy, not too bad. Juvenile retinoschisis, as long as they don't have bleeds or a retinal detachment, they're not too bad. Best, of course, autosomal dominant is, definitely okay. Early onset Stargardt, like I said, is probably, quite a severe disease. I'll just take a few seconds. So what does a nonsense mutation, mean? So when you look at a mutation like this, here, the arginine amino acid here has been terminated. So when a change in the amino acid creates a stop codon, there is no formation of the protein from that point, so it's called a nonsense mutation. That's much worse than what you would see, for example, so for example, in, something like, sorry, I don't have an example of that. Okay, so if there is just a change in the codon with there's no stop codon being initiated, that's called a missense mutation. So they tend to do much better than nonsense mutations. So there are very specific mutations, for example, in Stargardt that actually have a better prognosis. So a lot of information is available about this, genetic mutations today. So what is the take home? Diagnosis, phenotype is the key to interpret the genotype. Prognosis, of course, multifactorial, and clinicians have a very, very keen role to play. Thank you so much.
Thank you, Dr. Raj.